Good morning. I am Dr. K. Anand Manjunath, consultant interventional cardiologist and assistant professor of cardiology in Chettinad Academy and Research Center, Chennai. So today we will be talking briefly about the pacemaker rhythms. So what is a pacemaker? Pacemakers are electronic devices that stimulate the heart with electrical impulses to maintain or restore a normal rhythm. Normally, the heart has its own pacemaker, which is the SA node. When the SA node fails to generate an impulse, or if the impulse is not conducted to the AV node, or the AV node has some intrinsic defect which cannot pass on to the ventricles, then the patient will have symptomatic bradycardia, and that is the time we will need a pacemaker. So what are the components of the pacemaker? The pacemaker generally has two components. One is the pulse generator and the second is the pacing lead. The pulse generator is placed via a small surgery in the left side of the chest, or sometimes in the right side of the chest also, and it has a small pacing lead which connects the pace generator to the right ventricle or the right atrium based on the type of the pacemaker. In a temporary pacemaker, it is achieved by an external generator. The pulse generator, which is not inside the body, it is there outside. So this is an X-ray of a patient with a permanent pacemaker. This is the pulse generator. This lead is connected to the pulse generator, and it goes through the veins to the right atrium and to the right ventricle. You can see the end of the pacing lead. So this will generate impulses to the heart. So what are the broad types of the pacemaker? One, it's a temporary pacemaker or a permanent pacemaker. It goes with the name. Temporary pacemaker is bound to stay only for a short period of time. Like say in a patient with acute myocardial infarction, if he had developed a complete heart block which is expected to resolve in a matter of time, then we can go for a temporary pacemaker. It's only as a temporary solution. And second is a permanent pacemaker. Permanent pacemakers are bound to stay for a longer time, and they usually stay for 10 to 12 years. After that, we just replace the pulse generator. It can be either a unipolar or a bipolar pacemaker depending on the type, and based on the chamber paced, whether it's as a single chamber or a dual chamber, or if it's a biventricular pacemaker, which is the CRTD or CRT. So a single chamber, it can pace either the atrium or the ventricle. Dual chamber paces both the atrium and the ventricle, generally the right atrium and right ventricle. Biventricular pacemaker paces both the right atrium, right ventricle, and also the left ventricle. So what are the recommendations for pacemaker implantation? This is generally for permanent pacemaker implantation. So you can see symptomatic bradycardia, that is heart rate is less than 40 per minute with frequent symptomatic sinus pauses, and symptomatic chronotropic incompetence, that is the heart is not able to increase its rate with activity. And also in patients with symptomatic bradycardia, that is from required drug therapy. Some drugs which cannot be stopped causes bradycardia. In that cases, we have to have a pacemaker inside too. It is also recommended, class 2A recommendation. The first three were class 1 recommendations. The class 2A recommendations are sinus node dysfunction occurring with heart rate less than 40 per minute when a clear association between significant symptoms consistent with bradycardia and actual presence of bradycardia has not been documented. We do a 24 hours Holter monitoring, and then if we are not able to associate the syncope or giddiness with a bradycardia, then it's very unclear. So that comes into 2A recommendation. If it is documented, then it comes to class 1 recommendation. And also a syncope of unexplained origin when patient has clinically significant sinus node dysfunction, that is discovered or provoked during EP study, not routine ECG or a Holter, by EP studies. And class 2B recommendation is when patient is minimally symptomatic patients with chronic heart rate less than 40 per minute while awake. And class 3 recommendation, that it should not be done in sinus node dysfunction in asymptomatic patients. Sinus node dysfunction in patients with symptoms are clearly documented in the absence of bradycardia. Like the heart rate might be 40, 50, 60, and still if they have giddiness, it is not related, and we should not put a pacemaker in those patients. And also, if the sinus node dysfunction is associated with symptomatic bradycardia that is caused by non-essential drug therapy, suppose say patient is on beta blocker and that has caused a bradycardia and complete heart block. So what we do is we just stop the beta blocker and then we observe for maybe for 3 or 4 days, and usually the heart rate comes back to normal. In that case, we should not say it's an indication for a pacemaker, and we should not put a permanent pacemaker in that patient. So we'll talk about individual types of pacemaker. So first is the single chamber pacing. So it can be either single chamber atrial pacing or single chamber ventricular pacing. So in atrial pacing, in whom do we do an atrial pacing? In patient with isolated sinus nodal dysfunction with intact AV conduction. That is, the sinus node might not be able to produce the impulse, but it is conducted to the ventricles. The common modes, the codes will be AAI or AAIR, and it can also be a single chamber ventricular pacing. That is the same but we do it in the ventricle. Only the right ventricle is placed. This is done in chronic atrial arrhythmias with slow ventricular rates. Say in patients with atrial fibrillation with complete heart block, in those patients we do. And also the main criteria is main thing is the patient should have an underlying AV block. So this single chamber ventricular pacing is usually VVI or a VVIR. So next, dual chamber pacemaker. Dual chamber pacemakers has 2 leads. One is placed in the RA and one is placed in the RV. This maintains the AV synchrony. Why is AV synchrony important? Because AV synchrony means it is the most physiological component. That is, the atrium contracts and then the ventricle contracts. Both don't contract at the same time, or the ventricle doesn't contract first followed by the atrial contraction. The atrium contracts and the ventricle contracts. So the pacemaker code for this dual chamber pacemaker will be DDD. So what is the pacemaker codes? I have talked about AAI, DDD and VVI. What are they? So there is 2 societies for electrophysical studies and pacing. One is the North American Society of Pacing and Electrophysiology and the British Pacing and Electrophysiology group. They sat together, the Americans and the British sat together and they formulated a code, the NBG code, in 2002. So what is the code? This has a group of 5 codes, 5 numbers. First indicates the chamber paced, the chamber sensed, the response to sensing, the rate responsiveness, whether the pacemaker can increase its rates with the patient's need, and also multi-site pacing. Usually multi-site pacing I will not be discussing in this class, so we will talk about the first 4. So as we said, this is the chart. So first we will see what is the chamber paced. Definitely the patient will be on a single pacing lead, at least they will have a pacing lead in the atrium or ventricle. So it should be either be A, B or D. It will never be 0. It will be either be A, B or D. D means it's a dual chamber pacemaker. Both atrium and the ventricle are paced. Second also same. You will always be able to sense the either atrium or ventricle or both. So it will be AA, VV or DD. And response to sensing, that is whether the pacemaker senses that there is no impulse which is coming, and it either puts in impulse or it inhibits the impulse. The pacemaker is bound to provide an impulse. So that's triggered, we generally don't use it because it is its duty. So if it is inhibited, then that we include in the stating. So we will say it is atrial sensed, atrial paced and inhibited. The rate, if there's already an atrial impulse which has come, it will not pace. Same like the DDD, we can both trigger or inhibit the impulse. And the last thing, the 4th chamber, what we have called will be the rate modulation. It will either be 0 or R. So R means it can rate modulate. That means the heart rate can increase or decrease with the patient's exercise. So the patient will be comfortable when he walks, his heart rate will increase and the pacemaker also will support that. So if the patient has a AAI, it means he has a pacemaker, single chamber pacemaker, which is A and I inhibition. That is, it goes with it. So AAI, and if it's AAIR, it means it has a rate modulation, that is the patient can do an activity and increase the heart rate also. So, AI means atrial pacing and atrial sensing. If the native atrial activity, that is the sinus node has produced the atrial impulse, then the pacing is inhibited. If there is no atrial activity sensed for a predetermined time, say like 1000 milliseconds, if there is no P wave which is coming, then the atrium will pace, and that will cause a QRS complex, and this should be done only in patients with intact AV conduction. It should not be done in a patients without intact AV conduction. So, what will happen? So, if the pacemaker will pace, and then there is AV conduction is impaired. So, what will happen? The PR will prolonged, and the QRS might form or might not form. So, definitely if the patient has a normal QRS, normal AV conduction only, we have to put a AAI pacemaker. So, what is a VVI pacemaker? VVI pacemaker is a single chamber pacemaker, and this is the cheapest alternative to a DDD pacemaker. DDD pacemakers are the most efficient, and they are most physiologically correct pacemakers. This will have its own demerits, because what happens is it paces the ventricle. So, the intrinsic ventricular activity is stimulated. So, what happens? The QRS will be broad. So, the QRS will be more than 120 milliseconds. So, it will always be the QRS will be broad. So, the QRS will be more than 120 milliseconds, and that can be seen because we are pacing the right ventricle, it will be seen as the LVV morphology in the ECG. So, it is used in patients with chronic atrial impairments, like in patients with atrial fibrillation or flutter with impaired AV conduction, and with low ventricular rates we put them on VVI pacemaker. So, the main disadvantage is it lacks AV synchrony. The atrium will beat on its own, but the ventricle will be pacing at its own, like there has been no coordination between the P wave and the QRS complex. It is almost like a complete heart block, but the ventricular rate will be increased. The more incidence of pacemaker syndrome occurs with VVI, but still VVI is currently used because of the cost factor, and it has the ability to pace the ventricle, and the rate can also be adjusted. So, we can have VVIR also, or a VVI. So, what is a DD pacemaker? DD pacemaker is the most widely used code of the pacemaker which is used. More than 85% of the people who undergo pacemaker undergo a DDD pacemaker. So, what happens? Both the atrium, we have a lead in the atrium and the ventricle, and both the atrium and the ventricle are sensed, and if the atrial pacing occurs, if the atrial pacing occurs if there is no native atrial conduction, and ventricular pacing occurs if there is no native ventricular activity and following the atrial activity. I will show a few examples of the ECGs. So, what is a magnet mode? So, magnet mode usually initiates a asynchronous pacing. What will happen is the pacemaker which the patient is on will either become a AOO pacemaker, VOO pacemaker, or DOO pacemaker. What we do magnet mode means we just take a magnet and place it over the pacemaker, and we take a ECG. So, what happens is the pacemaker will deliver a constant pace stimuli regardless of the native rhythm. It will not sense, it will just pace, and if asynchronous ventricular pacing is placed, we have to do it only in the hospital, and it has to be monitored because there is always a risk of pacemaker induced ventricular tachycardia. So, you can see this is a patient with a pacemaker, and this is on a patient with VVI pacemaker with a magnet. So, what you can see is almost all the QRS complex is preceded by a small pacing spike. The small positive inflection you see is the pacing spike, and all the QRS complex is preceded by a pacing spike. So, there is no, all the QRS complex are of same morphology, that is the LVB morphology, and all the complex is preceded by a pacing spike. So, the pacemaker is in the magnet mode, that is the asynchronous mode, and it has caused the function. So, what is a pacemaker syndrome? See, a pacemaker cannot replace the natural conductive system of the heart. We do the best to attain the maximum physiological effect by using a DDD pacemaker, but if we do not use a DDD pacemaker and we go with a VVI pacemaker, we can end up in pacemaker syndrome. It happens because of the clinical consequences of suboptimal AV synchrony or AV dyssynchrony regardless of the pacemaker mode after the pacemaker implantation. It can happen because of retrograde atrial activation during ventricular pacing leading to simultaneous atrial and ventricular contraction. So, both contract together, what happens? The cardiac output is decreased, the stroke volume is decreased, and all they decrease the low cardiac output state, which causes syncope, near syncope, fatigue, palpitation, and giant cannon A waves and prominent pulsations in the neck. So, this is more common with VVI pacemaker, and it can be it's less common in patients with DDD pacemakers. So, I will show you a few examples of paced ECGs. So, first we have this ECG. You can see the ECG. You can see the patient has a P wave and a QRS complex and a small T wave also. But you can see preceding every P wave there is a small paced rhythm is there. So, this is there before every atrial beat. So, this is a pacemaker which paces the atrium. So, it is a AAI pacemaker. It can be AAIR also, but we cannot say with this ECG alone. So, most probably it is a AAI pacemaker, and you can see the PR is quite prolonged. The PR interval is supposed to be less than 200 milliseconds. You can see here, if it is here, it is more than one box. So, it is more than 200 milliseconds. So, this patient has an underlying AV block also. So, this is a single chamber pacemaker at 60 per minute. So, the heart rate is 60. 1, 2, 3, 4, 5, almost 5 boxes, 300 by 5 is 60. And the PRL interval is prolonged with which determines there is patient underlying AV nodal disease, and the patient might require a dual chamber pacemaker in the future. So, this is another ECG. And you can see the patient has two pacing spikes, one in the first and second, and then it is followed by a QRS complex. So, this is seen in almost all leads. So, this it happens at a rate of around 70 per minute. So, this is AV synchronous pacing. This most probably is a DDD pacemaker, which can be a DDDR also, and this is a AV synchronous pacing, equisequential pacing. So, both the atrial contraction, that is the P wave, and the QRS both are preceded by a P wave, by a pacing spike, and then the pacing occurs. So, this indicates there is 100% capture and 100% pacing. Sorry. So, this is another example of ECG which shows there is a broad complex QRS. So, that means the ventricle is paced, and it is in the LBBB morphology. So, that means it is a right ventricular pacing. So, it can be a VVI pacemaker, and almost all the leads are preceded by a pacing spike. So, this is a pacemaker which is a VVI pacemaker, and it is seems to be functioning normally, and the heart rate is around 70 per minute. So, wide QRS, there is no atrial pacing spikes. So, this is a VVI pacemaker. So, this is another example. This is also similar to the ECG which we saw earlier. Every complex is preceded by a QRS complex. P wave is preceded by a pacing spike, atrial spike, then there is a ventricular spike, and then there is a QRS. So, this is also AV synchronous pacing and simultaneous pacing with 100% capture and 100% pacing. So, this is another example, and yes, this is a pacemaker which is a ventricular pacemaker, right ventricular pacemaker, because of the LBB morphology. This has a slight RBB morphology in the leads which are the native leads. Other the pacing leads are all in the LBB morphology. So, before the ventricle is paced, you can see a pacing spike in the ventricles before the QRS complex, and this two beats are not wide. So, this is the beat which is produced natively from the patient. So, that is the it can be either a capture beat, which is the native beat, or it can be and it's a very it's a narrow complex beat. So it happens before the level of the AV node. So it is a supraventricular beat. So this is a ECG in a patient with VVI pacemaker most probably, and the narrow QRS complex or non-capture beats. So this is another example. You can see the patient has a normal P wave and the QRS is preceded by a pacing spike. So this is also, and it's a wide QRS and it's also LBB morphology, and so this is a VVI pacemaker most probably, or a VVIR pacemaker, and the pacemaker is pacing at around 70 per minute, and this might have been a patient with AV nodal dysfunction with a prolonged PR interval, or a patient with complete heart block who has underwent a pacemaker. So, I will tell you about a small case scenario. So, this patient had a history of cardiac surgery in the form of aortic valve replacement like 10 years ago. He came to us with complaints of giddiness. So, initial clinical examination was absolutely normal and the valve was functioning well in echo. So, we did a ECG. You can see there is a brief periods of without QRS activity. There are only P waves which are not conducted. So, we were able to capture this in the routine 12 lead ECG, and this is a sinus pause. So, what we did, we went ahead and we talked to the patient and we put him on a VVI pacemaker. So, you can see this after the pacemaker insertion, this is the patient is on his own native rhythm, not requiring a pacemaker. You can see there is no pacing spike, the ventricle has sensed that there is an intrinsic impulse which is coming and it has not paced. So, this is the patient's intrinsic rate. So, next ECG you can see the initial 1, 2, 3, 4 are the native beats which has the narrow QRS, and the subsequent beats are all wide complex, and it is preceded by a pacing spike and is of LBBB morphology. So, it is a VVIR pacemaker and this is without a magnet. So, the same patient, when we put a magnet, it has completely abolished all the native impulses and it is just pacing at its own rate. We have set a pacemaker around 80 per minute, the magnet's rate was around 80 per minute, and you can see the heart rate, the ECG is pacing at 80 and there is no native contraction. You can see here there was a native contraction, and in this ECG the native contraction has been abolished. So, this is another example of a pacemaker. This is also a ventricular pacemaker, most probably a VVI pacemaker with the LBB morphology, and it can be a DDD pacemaker also. We cannot say because the P waves are present, so it might not, it could have sensed and not paced, and so this is atrial sensed or we paced. Okay, so as I said, because the atrium P waves are present, it didn't pace, and the ventricles are paced. So, it is a DDD or pacemaker, and this is of the same patient. After 1 or 2 days, you can see the atrial sensing works properly. You can see that here there is atrium sensed and there is no ventricle beat. So, there is a ventricular pacing spike, but there is no QRS. Again here there is atrial sensed, there is a spike, but there is no QRS. So, there is failure of capture, like the pacemaker is producing a spike which can be seen in the surface ECG, but it is not captured by the ventricle. So, this means there can be the position of the lead might have been changed. So, atrial sensing is proper, there is lots of ventricular capture because of a misplaced lead. So, this is another example of a patient who came to us with a cardiogenic shock with bradycardia. His heart rate was barely 40, and you can see in the ECG he had a widening of QRS complexes with a missed beat. It can be a 2 to second degree AV block or complete heart block also, we can't say, with ST elevation in V3 to V6. So, this was a massive MI. We put him on a temporary pacemaker. After we put him on temporary pacemaker, you can see the intrinsic conduction has changed into LVB morphology. So, we have paced the right ventricle, and all the ventricular beats are preceded by a small pacing spike. So, this is another example of a pacemaker. This you can see this native atrium is there, and there is a this is a native atrial and ventricular beat, and these two beats look abnormal. So, this looks like a patient with a LVB morphology, and so these two might have been a paced effects. You can see, if you see here carefully, you can see the small pacing spike is seen here. So, it is most probably a VVI pacemaker, and see this, you can see the pacing lead, it has moved down. This is the gentle position, it has moved down, and the lead which is supposed to be in the RV has moved all the way up to the right atrium and is somewhere floating. Thank you.